All right, it's 12:30, everyone, so let's get started. So thank you all for joining us for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engage in the session, keeping your camera on when appropriate, registering for CME credit for each session, and completing and submitting a session eval form. Next slide, please. So here's the activity code for today and how to claim your CME credit. So I'll leave this up here for a little bit so you can all get your CME credit. All right, next slide, please. And again, here's just more information about how to get that CME credit via text. And next slide, please. And then this is just information regarding the CME transcripts and how to access those. Next slide, please. And this is just a slide regarding the AAFP credit system. Next slide, please. And then these are the core competencies that we will address in our grand rounds. Next slide, please. Emily Tran has no financial relationships with ineligible companies to disclose. All right, next slide, please. And Dr. Nato has a brief introduction for us.
Emily Tran to present at our grand rounds. Emily is a psychology resident at UT Health San Antonio, with her major rotation being at the Center for Health Care Services. She also completed a practicum rotation at CHCS, making this her second year working in primary care as a behavioral health consultant. Emily is passionate about providing accessible patient care to patients wanting to improve their mental and physical health. As she approaches graduation at the end of this academic year, Emily intends to extend her commitment to working in integrated care as a postdoctoral fellow. So with that, I'll introduce Emily Tran. Thank you for joining us.
Hi, everyone. Thanks for having me. Oops. Let's see. Today, I'll be talking about integrating the recovery model into primary care. And I appreciate everybody being flexible and meeting on Zoom today. The objectives are for you all to be able to define the aspects of the recovery model mindset, employ the recovery model with patients, and then be able to recognize the differences between patient-centered and physician-centered care by the end of this presentation. So I will talk about who it's important to talk about the recovery model in primary care for. We have more than 1 in 5 people with a behavioral health condition in the US. That totals up to 22.8% of adults having a diagnosis of any mental illness, where any mental illness means a mental, behavioral, or emotional disorder. And AMI can vary in impact ranging from no impairment to mild, moderate, or severe impairment. And then we have 5.5% of adults having a diagnosis of serious mental illness, where serious mental illness means mental, behavioral, or emotional disorders resulting in serious functional impairment, which substantially interferes with or limits one or more major life activities. We then have 7.6% of adults who experience a co-occurring substance use disorder and mental illness, and then 16.5% of youths aged 6 to 17 having a diagnosis of any mental illness. And so here we break down any mental illness so that there are let me back up. 57.8 million adults in 2021 were diagnosed with any mental illness, which represents that 22.8% of all US adults. The prevalence was higher among females, young adults aged 18 to 25 years old, and was highest among those reporting 2 or more races. 14.1 million adults 18 and older are estimated to have SMI or serious mental illness, which accounts for that 5.5% of all US adults. Prevalence was highest among females, young adults again, aged 18 to 25, and those who identify as Asian Indian and Alaskan Natives. We know there's a connection between mental and physical health and that they will impact each other, and those of us in primary care are doing a significant amount of the work regarding behavioral health concerns. So as many as 70% of primary care visits are driven by behavioral health concerns. More than 80% of patients with medically unexplained symptoms receive psychosocial treatment by a PCP, and out of those, only 10% will follow up with specialty behavioral health care. People who have a serious mental illness diagnosis, on average, die 29 years earlier than those without an SMI diagnosis. So, like I just said, in primary care, you have a really high probability of treating somebody with any mental illness or serious mental illness. It's really important to treat those with SMI because of the increased morbidity rates. People often think that 29-year sooner death is because of the serious mental illness, but it's actually as a result of the physical health conditions that they have and the troubles they have getting treatment for those conditions. People who treat SMI have pushed a model of bringing the health concerns together, which is the CCBHC model. The Certified Community Behavioral Health Clinic model, or CCBHC, is a federal model of integration founded on person-centered treatment, care coordination, and integration, evidence-based practice, timely access to care, including 24/7 crisis response, and the flexibility to deliver support outside the four walls of the clinic. CCBHCs must meet standard criteria that includes, but is not limited to, staffing, timeliness of access, quality reporting, and scope of services. While many of these services are available at other community-based organizations, few traditional providers like community mental health centers or federally qualified health centers are able to offer the entire array of CCBHC services and supports. Special funding like grant funds or a Medicaid cost-related payment rate support CCBHCs in the full anticipated costs of carrying out those activities. So you can see in those blue squares on top that CCBHCs provide screening, assessment, diagnosis, patient-centered treatment planning, outpatient mental health and substance use disorder care, and 24/7 crisis services within the CCBHC. And then on the bottom, in the green squares, we have peer support, psychiatric rehabilitation, targeted case management, primary health screening and monitoring, armed forces, and veteran services. And so those can be provided within the CCBHC, or they can be contracted through a third party. CHCS is unique because we provide all of those services from within. So we provide the deluxe model also because we don't just screen, we actually provide primary care services for our population. So these CCBHCs are the new model of community mental health clinics with the aim of improving access and health outcomes. As of January 2022, there were 32 CCBHCs certified by the Texas Health and Human Services Department, 29 of which were local mental health authorities or local behavioral health authorities, and 2 were nonprofits in 187 counties, serving 89% of Texans. And then CHCS serves that part of Texas right there. CHCS is one of 38 local mental health authorities in Texas providing treatment for SMI, intellectual and developmental disabilities, and substance use disorders. The emphasis is on safety net services for the uninsured and underinsured, and sponsoring agencies are Bexar County and University Health Systems, or the Bexar County Hospital District. The Board of Trustees is comprised of 5 appointees from Bexar County and 4 appointees from UHS. And so we have a breakdown of our services here, starting with adult behavioral health. That includes integrated primary care, our therapeutic justice programs, and our complex care programs. We also have children's behavioral health, which has complex care. We have our restoration center, which is focused on substance use treatment. We have our community and crisis response, which includes detox, crisis, sobering unit, and outreach for Haven for Hope, and then some integrated teams with law enforcement and clinicians. So if y'all are familiar with MCOT, the SMART team or the PIC team, those are some joint teams here in the city through the crisis and community response team. And then we have intellectual and developmental disability services as well. So I'll start touching on the bi-directional opportunities in an integrated system of care. First, we have here a traditional model of integration where behavioral health services are embedded into the physical medicine clinic. And then we have the bi-directional integration, which was previously known as reverse integration, where we bring the physical health into the behavioral health clinic. CHCS uses bidirectional integration in its team-based approach to primary care. So rather than primary care being the main service here, psychiatric services are the predominant service, with primary care integrated into those services, and then behavioral health consultation services being integrated into that. So we affectionately refer to our services here as a turducken, if anybody's ever heard of that. Turkey would be the psychiatric services, then the duck would be primary care, and then our chicken would be BHC or behavioral health consultation. And then CHCS provides a robust team of experts to make it convenient for patients to receive all of their services in one place. So you can see the BHC, the PCP, nursing team, case management, the psychiatric prescriber, peer specialist, and then our integrated care coordinator, who is an RN. The BHC team travels between clinics so that we can get to as many patients as possible. So since I'm the psychology resident, I rotate with a couple of our licensed psychologists at our Northwest Clinic, which is pictured there, the Paul Elizondo Clinic downtown by UTSA, and then one that's not pictured, which is the Restoration Center over by Haven. And so we work in primary care with the providers. We use the same exam rooms, the same EHR, and we have flags on the outside of the doors that you can see here that indicate who is in the room at all times, so that we can all stay on the same page. So what is the recovery model? I'm going to start just to give us a point of comparison with the traditional or medical model. This model is based on the idea that mental health and emotional concerns are analogous to biological problems. They have detectable, specific physiological causes and are amenable to cure or improvement by specific research. So in this model, the problem tends to be physician-defined. Recovery is not a cure, only decreasing or eliminating symptoms or deficits, waiting until all symptoms are gone before moving ahead with life, a specific or a separate service, a checkbox on an intake, and it's not only applied to substance use or substance use recovery, which is what most people think of when they hear the recovery model. And so we have the Substance Abuse Mental Health Services Administration, or SAMHSA's working definition of recovery. They say that recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Next, we have a quote from Patricia Deegan, who is a licensed psychologist who was diagnosed with schizophrenia. While talking about recovery, she said, "When one lives without hope, when one has given up, the willingness to do is paralyzed as well. For many of us who are disabled, recovery is a process, a way of life, an attitude, and a way of approaching the day's challenges. It is not a perfectly linear process. At times, our course is erratic and we falter, slide back, regroup, and start again. Recovery is the urge, the wrestle, and the resurrection. Recovery is a matter of rising on locked limbs to a new life." The recovery model supports a fundamental shift from the medical use of the word recovery, which is traditionally meant being symptom-free or cured. Instead, this new perspective conceptualizes recovery as a way of living a satisfying, hopeful, and contributing life, even with limitations caused by the illness. Recovery involves the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. The recovery model is based on the premise that recovery from behavioral health conditions is possible. The best and most effective recovery is person-centered. People with SMI can lead meaningful and satisfying lives. So there are 4 dimensions that support a life in recovery. First, we have health, which refers to overcoming or managing one's symptoms and making informed, healthy choices that support physical and emotional well-being. We have home, which refers to having a safe and stable place to live. Purpose, which refers to having meaningful daily activities like work, school, volunteering, or creative endeavors. And the independence, income, and resources to be able to participate in society. Lastly, we have community, which refers to having relationships and social networks that provide support, friendship, love, and hope. And then to break that down even further, we have the 10 guiding principles of recovery as defined by SAMHSA. All right, so first we have hope. Recovery emerges from hope, which can be fostered by peers, families, providers, allies, and other people in the individual's life. Hope is the catalyst of the recovery process. It's the belief that recovery is real, provides the message of a better future, and that people can and do overcome the challenges, barriers, and obstacles that they face. Recovery is also person-driven. Individuals optimize their autonomy and independence as much as possible by leading, controlling, and choosing the services and supports that help their recovery and resilience. In doing so, they are empowered and provided the resources to make informed decisions, initiate recovery, build on their strengths, and gain or regain control over their lives. Self-determination and self-direction are the foundations for recovery as individuals define their own life goals and design their unique paths towards those goals. Recovery occurs via many pathways. These pathways may include things like professional clinical treatment, using medication, faith-based approaches, or peer support, among other approaches. Recovery is nonlinear and characterized by continual growth and improved functioning that may involve setbacks. Because those setbacks are a natural part of the recovery process, it's really important to foster resilience for all individuals and families. Recovery is built on the individual's capacities, strengths, talents, coping abilities, resources, and inherent value. And the recovery pathways are highly personalized. Recovery is also holistic and encompasses an individual's whole life, including mind, body, spirit, and community. It's important to integrate each of those areas as much as possible when working with a patient. Recovery is supported by peers and allies. Talking with others who have a lived experience with substance use and/or behavioral health conditions can be incredibly impactful. Peers encourage and engage other peers and provide each other with a vital sense of belonging, supportive relationships, valued roles, and community. Recovery is supported through relationships and social networks. Family members, peers, providers, and other important people in the individual's life create those support networks. Through those relationships, people can engage in new roles like being a partner, caregiver, friend, student, or employee, leading to a greater sense of belonging, empowerment, autonomy, and social inclusion. It's important to be surrounded by people who believe in the person's ability to recover and offer hope, support, and encouragement. Recovery is also culturally based and influenced. Services should be culturally grounded, attuned, sensitive, congruent, competent, and tailored to that individual. Culture, including the individual's values, traditions, and beliefs, is key to figuring out the best pathway to recovery. Pathway is also supported by addressing trauma. Trauma experiences can lead to alcohol or drug use, behavioral health concerns, and related issues. Services and supports should be trauma-informed to foster safety, both physical and emotional, and trust and promote choice and collaboration. Recovery involves individual, family, and community strengths and responsibility. In addition, individuals have a personal responsibility for their own self-care and journeys of recovery. Individuals, families, and communities have strengths and resources that serve as a foundation for recovery. Recovery is also based on respect. So we need to acknowledge that taking steps toward recovery may require a lot of courage for the individual. Self-acceptance, developing a positive and meaningful sense of identity, and regaining belief in oneself are particularly important. Community, systems, and societal acceptance and appreciation for people affected by mental health and substance use problems are crucial in achieving recovery. So why is the recovery model important? We're going to do a little thought activity for just a second. So I want everyone to think about the last time they may have weighed themselves and the number on that scale. Or I know we all spent many, many, many years in school. So thinking about the kinds of grades you got while you were in medical school or your psychology program or anywhere else. If someone saw only those numbers, would they know you as a person? What else is missing outside of those numbers? How would it feel to be defined only by those two facts? This is why the recovery model is important. That feeling of everything that's missing when we narrow a whole person down into those diagnoses and symptoms. There are a lot of benefits to the recovery model. The recovery model involves many aspects of life that are common to all people, which promotes shared concerns. It also creates positive expectations for those in the recovery process, supports strong peer culture, instills hope, reduces symptoms, improves quality of life, and shows better employment and education outcomes. So how can you implement the recovery model in primary care? Staff attitudes are really important in shaping rehabilitation environments. There are many common attitudes that are particularly unhelpful to recovering people. For example, people may implicitly send the message that there is a world of the abnormal and a world of the normal, where the task is to move people from the abnormal world to the normal world. This creates an us versus them dichotomy where they are expected to do all of the changing and growing. This puts the provider and staff in a really safe position as they get to continue sitting in the normal world. When the us versus them attitude prevails, providers and patients are worlds apart. So some things that are common to hear, depending on where you are, is you've got a knee infection in room 2, or you've got a flu patient in room 1. Both of those can take away the person's identity and boil them down to the presenting concern. One thing you can do is using recovery language in your documentation. So recovery language is person first, strengths-based, humanizing, normalizing, contextualizing, and time specific. So instead of saying addict, you may say a person with a history of substance use or a person with an addiction. Instead of saying schizophrenic, you may say a person with schizophrenia. Instead of saying non-compliant, you may say disagrees with treatment recommendations or has other ideas for how to get better. Instead of resistant, you could say not open to, chooses not to, or has concerns about. And instead of unmotivated, you could say has other priorities, doesn't know where to begin, or has X barriers in place at this time. So those are just a few examples. So we'll go through a couple of case examples as well. First, we're going to talk about Amanda. Amanda was a patient at CHCS. She was a 56-year-old Hispanic female coming in for hepatitis C treatment. And her list of diagnoses, she had heroin use disorder severe, cocaine use disorder severe in sustained remission, bulimia nervosa, major depressive disorder, recurrent episodes severe, generalized anxiety disorder, hypertension, and of course, chronic hepatitis C. She used cocaine for 14 years and used heroin for 19 years. She overdosed in 2023, which led to a hospitalization, which then led to her being transferred to the residential treatment program we have with CHCS. Her husband died in early 2023, which was just before the overdose. She found out about the Hep C when she entered the residential treatment program and probably contracted it through dirty needle use, but she's not 100% sure. She started Maverick, which is the medication that we use here, on March 4th and has been medication adherent. So if we were to conceptualize Amanda from a non-recovery oriented framework, we might see her as just an addict. We might not consider other facets of Amanda's context. We may focus on relapse rates rather than relapse prevention and Hep C treatment. And we could identify Amanda as resistant or unmotivated. If we were to switch that and conceptualize Amanda from a recovery-oriented framework, we would discuss the possibilities of being cured. We instilled hope that the patient can complete something important. We were person-driven with our approach to Amanda, making sure we explored her values associated with recovery. We used SMART goals which were created and tailored to her. Patient keeps her Maverick in her methadone box and reminds herself of her values each day so that she can stay medication adherent. We were holistic, so we considered her life experiences and how her mental health, physical health, spiritual identity, and sense of community impacted each other. We encouraged her to connect with peers at CHCS and peers from ITP, which is the Integrated Treatment Program, and the NA meetings that she was attending. We were also relational while working with her. So she was living in a dorm with other people who were newly sober. Her health team overtly believes that she is capable of recovery from both her mental and physical health diagnoses. She has a strong Catholic faith, which is considered each visit that we were working with her. She's Hispanic and recovery culture was also considered. So her faith was one of those things that really kept her going and is a big motivator in her staying sober and curing the Hep C. We did not discuss the trauma history, but if it arose, we would talk about how trauma might have impacted the Hep C treatment adherence and maintaining her sobriety. Her health team overtly highlights her strengths and resources every time we meet with her. And we always treat her with respect and autonomy. So a few takeaways for Amanda. We could have simply approached this as just medication adherence, but this is a huge milestone for Amanda. Many people we talk to who are undergoing Hep C treatment, Amanda included, say that this is the first time they've accomplished something in their life. It's a very reachable goal since it's 8 weeks of taking an oral medication. We have a lot of contact with them throughout the treatment, and there was a lot of growth from her and many of the other people we see for Hep C treatment. The key is not to ignore the substance use either. So being a sober person is a daily task for her. If you're not talking about it, you're leaving out one of the biggest thought patterns or experiences of Amanda's life. She also gets to claim victory over this, and we get to celebrate her achievements and support her through this process. Next, we have John. John is a 53-year-old single mixed male from New York City. His diagnoses include schizoaffective disorder, bipolar type. We have a suspicion of intellectual disability, but there's nothing listed there. He also has nicotine dependence, mixed hyperlipidemia, hypothyroidism, headaches, and allergic rhinitis due to pollen. He started smoking cigarettes at age 31, so it's been 22 years that he has been smoking cigarettes, and he's quit multiple times. Prior to October 2023, he was smoking up to a pack a day, received nicotine replacement therapy from a hospital in New York City. In October 2023, he was using 10 4-milligram nicotine lozenges per day, then decreased to 8 4-milligram lozenges per day. In November 2023, he reduced further to 6 4-milligram nicotine lozenges. He kind of fell off of our schedule for a while. And then prior to March 2024, he had increased again to 10 4-milligram nicotine lozenges a day and had a relapse of smoking cigarettes. So he was smoking the Marlboro Ultra Lights for a little bit. And then should say March 2024, he decreased again back to 6 4-milligram lozenges per day. So there were some fluctuations in how many lozenges he was using and then how much he was smoking. From a non-recovery oriented framework, someone may not consider other facets of John's context, reducing the nicotine reliance only to biological factors and that biological need for the nicotine. And they may identify John as resistant, unmotivated, and or lazy. We instilled hope that John could live a healthier lifestyle. He has been able to reduce the NRT usage before and was cigarette free at some point for 2 years. So he did go quite a while without smoking. We explored his values associated with cigarette and NRT cessation each time we met with him. We also considered other alternatives that he could use besides cigarettes and NRTs, like hard candies, straws, toothpicks, things like that. We also used SMART goals with him. They were created and tailored to him, considering his cognitive abilities. So I have a diagram over here that he was given, breaking down the equivalent of how many NRT lozenges he was using compared to cigarettes. So when I met with him at this point, he was consuming 6 4-milligram lozenges, which was equal to 60 Marlboro Ultra Lights. So if he was smoking, that would be a lot of cigarettes, and regardless, it's a lot of nicotine to have in your system. So that was very impactful for him. Considering the holistic piece, we thought about his life experiences and how his mental health, physical health, spiritual identity, and sense of community impact each other. He's really worried about developing lung cancer. We considered those substitutions that will positively impact the hyperlipidemia as well. So like I said, the straws, I think, were one thing we were trying to emphasize the most, maybe toothpicks, anything to help him reduce that nicotine consumption that wouldn't exacerbate the hyperlipidemia or any of his other conditions. We encouraged him to connect with peers at the center. We also took the relational framework, discussing how quitting smoking has impacted his social circle. He was smoking a lot to, get friends and have connections with women. His family is really supportive of him quitting smoking and the NRTs. And his health team overtly believes that he's capable of recovery from both his mental and physical health diagnoses. As far as culture, his home is New York City, which seems to be a lot more progressive in providing NRTs and providing resources for people who are unhoused. So he was actually able to get all of these prescriptions from New York because he was living on the streets, and they have a hospital there that has a program that helps people quit smoking. So that's how he initially got the prescriptions. He had not indicated any trauma history to us. And he has had previous successes with quitting and reducing the NRTs. So we try to highlight that every time we see him, that he does have the strength and previous experience with that. And again, we always treat him with respect and autonomy. So some takeaways for John. The key takeaways here are that the recovery model has to be embodied by the provider. It can be really easy to slip into a non-recovery oriented mindset. So it's important to think about what you believe about recovery and what is possible for patients as far as change goes, especially with those fluctuations in how much he was smoking and how many NRTs he was consuming. It can be very easy to blame it on the patient or just boil it down to him not really wanting to change. So it's important to think about all of the things I've talked about today as far as the recovery model. If you're going to see people with SMI, the journey narrative is key. So people really want to tell you about their recovery and their story. And with John, the intent was harm reduction. So he believed he was doing this by switching from cigarettes to the lozenges. And now he knows more about how much he has increased his nicotine consumption from the cigarettes to the lozenges. All right, and I sped through that. But what questions or comments do you all have about the recovery model or anything else I talked about today?
Dr. Tran, this is Dr. Hepburn. How you doing?
Good, how are you?
Good. Quick question on what's your success rate with adherence? You know, once you've entered into this great model, but just any notion of that, those percentages of getting them in the program and then continuing through this construct?
I don't have the data on that. I can give you a qualitative answer. Maybe if Dr. Aguilar is here, she's my supervisor, she may have more quantitative data. But we have, for the most part, people will come back and people talk about how they do want to be able to treat various things in their life. So as a behavioral health consultant, we work on that health behavior change, talking about both mental health and physical health and how they integrate. Smoking cessation is really difficult, especially since there is that biopsychosocial component with the physical need for the nicotine, a social aspect, and then the psychological reward they get from the nicotine. Hep C treatment has gone pretty well. We have pretty high success rates with that, I would say, off the top of my head. And then with just the recovery model in general, I think that people respond very well to it when we're working with patients as well as the providers over here and other staff. I hope that answers your question.
Oh, it does. And just for the residents, just encourage them when there is recidivism, just to get back in there and get back on the horse and try it again, you know, so that unfortunately will happen. Thank you.
Yeah.
Hey, Emily, it's Dr. Morgan. I'm here with Dr. Aguilar. So for
Hello.
us with the hepatitis C treatment, you're absolutely correct. And for anyone who doesn't know, I'm Dr. Ruth Morgan. I'm the medical director of primary care here for the Center for Healthcare Services. We've worked very closely with Emily, and she's great. But for us, actually, for the Hep C treatment, we have success over 80%. And a lot of that has to do with the screening, the education. We do lots of education with patients. So generally by the time we start them on treatment, right, we've made sure that they're ready. We've made sure that psychosocially they're ready to participate in their treatment. You know, because part of that is if we begin to treat them and they fall off of care and they're only partially treated, we don't really, because a lot of our patients are uninsured. And if they do not have insurance, you know, that PAP, that might be our only one chance at treatment for them. So we do a lot of screening, a lot of education prior to starting treatment on our patients. I hope that helped.
That's
Thank
excellent.
you, Dr. Morgan.
Dr. Nato, if this is an excellent model, can you give me a sense, like nationwide, if you're getting an advanced degree in psychology, how is everybody exposed to this, or for people exposed to this? What's sort of the current state of education on this?
That is a really good question. I would say, I don't know about every psychology program in the nation, but I would say as a whole, as psychologists, we are at least taught to think about, well, Dr. Ogbai commented, it's not the norm. It is not the norm to learn how to work in primary care from the recovery model. So this is very unique. It's hopefully going to become more widespread. But we are, as psychologists, taught to think about our biases that we may have and are constantly checking in with those. So from that aspect, we're hopefully all taught to be curious and think about these from a more holistic perspective, where at least as far as I know, in medical school, it makes sense that you are taught to consider the medical conditions. So my hope is that this will help at least spark some wheels to start turning. Another person commented in the chat that she was not exposed to this model in graduate school. She's the other psychology resident. I do see Laura's question in the chat also. She asked, are there like racial, ethnic, religious cultures that do not include recovery as part of their culture that providers should be aware of when considering a person-centered approach? I would say that's included in the recovery model. So if you think about that culture piece in the 10 guiding principles, you would talk to your patient about what their cultural beliefs are regarding treatment, depending on what you're doing, or their religious considerations that they might need. I was talking to a colleague while I was creating this presentation, and she was talking about how she knew someone who was trying to treat a patient with a bone marrow transplant, but because of their religious beliefs, that was not allowed. Like, she did not want it, she denied it, she said she would not accept it. So I think they were doing supportive care. And I'm sure as a doctor, that can be really hard to hear when you know that there is a solution and the patient does not want that solution, that is not accepted by them or their culture. So I think it would just be really important to talk with the patient and see if they have any hesitancies about what you're suggesting or advising they do.
Hi, Emily. It's Dr. Aguilar. Thank you for putting all this together. One of the things that I just wanted to comment about is that earlier when we were talking with our primary care providers here at the center, I was mindful, and this, you putting together this presentation was reminding me of how that, education is so important, as Dr. Morgan said earlier. And I think part of what is so key, especially if you have patients that are being actively treated in a center for severe mental illness. I know we don't have everyone. I know there's a lot of folks that you all see in primary care that might already be in treatment somewhere else, or perhaps at our center, is to help our patients understand that sometimes there's a difference between some of the things you're recommending. I think sometimes our patients have a difficulty distinguishing between treatment and recovery versus preventative care. So for example, I know in our primary care, when we recommend mammograms or colonoscopies, patients have a hard time understanding that that is not a treatment, but it is optional. But they have a hard time distinguishing those things. And so I think that's one way that the recovery model mindset might influence patients to approach care in a different way. And again, it's about being able to take the time to help them understand that if you're recommending a mammogram, it's for a preventative effort and not necessarily from a treatment standpoint. They know that they have to undergo a procedure, and that might be the biggest, most salient thing in their mind about the particular procedure. So thinking about that in those discussions and in your care, I think is very helpful, especially if a patient only has ever known healthcare through the recovery model lens. I just kind of wanted to make that point. Thank you, Emily.
Thank you, Dr. Aguilar. Any other questions from the group? You could unmute or put it in the chat and I'll see it. All right, I did see someone ask for the slides. I am okay sharing them. I don't think I put my email on here, but I can put my email in the chat in case anyone wants to ask for them. Oops. All right, well, just to summarize the main points from my discussion with you all today, I hope that now you can identify different aspects of the recovery model and medical model mindsets. Consider these two case examples as an example on how to employ the recovery model with patients and be able to recognize the differences between patient-centered and physician-centered care and how to integrate the two. All right, well, thank you so much.